What's wrong with healthcare right now? Why, you're having to close clinics. We hear about the exorbitant amount of patients that you see. Let's start with that, first of all. People sometimes are shocked at the size of ECU, particularly the hospital here in Greenville. How many patients do you see compared to other hospitals in the state of North Carolina? Are we number one still?
Well, obviously the patient numbers move day to day and that sort of thing. But as a pattern and theme, I always start with every year Beckers releases a report where it just looks at the size of hospitals across the country and just puts them in order, kind of thing. And our hospital here in Greenville, believe it or not, ranks somewhere in the 13th or 14th largest hospital in the United States. And that is astounding when you consider how many great institutions there are in the nation. It's mind-blowing when you consider the fact that there's 80,000 people in Greenville, North Carolina, and we're talking about 13th largest when there are hospitals in towns of millions of people. This is an extraordinary large facility, and even more so when you consider the size of the community that we're in. That's both a blessing to the people of Eastern North Carolina, and it's a tremendous liability in that we have to staff a hospital that is as large as any metropolis in the country from a community that is small. And that creates a real challenge when you think of it from that perspective. This hospital is very large because it serves such a large region. We have patients that come from 29 counties in Eastern North Carolina.
But it's probably hard to recruit employees from 29 counties.
That's right. I can get patients coming from ambulances from all over, but having staff get in the car and drive through Eastern North Carolina an hour and a half to 2 hours is obviously much more challenging. But we have seen over the years, this hospital usually is one of the nation's largest interfacility transfer hospitals, meaning that patients come from another hospital and are transferred to a higher level of care. We do that as much as all the top 10% in the nation. So it's a very big, it's a very busy hospital when you compare it to any organization nationally in one of the smallest contexts of a community that there can be.
Why did you have to close these clinics?
Well,
you announced last week you're closing 5 clinics.
Yeah, we are having to adapt and adjust to the industry itself and how, obviously our ability to fulfill our mission is all contingent on the resources to do that. Healthcare has gone through an incredibly challenging time. I was looking at some statistics recently. Half of all the U.S. hospitals are operating with negative margins right now. In North Carolina, more than 60% of the hospitals have a negative operating income right now. So this is not just a local issue here. This is a national issue. And in the state of North Carolina, it's even more profound.
But why has it changed so profoundly this quickly?
In this peri-pandemic environment, there have been some real changes structurally to what we're doing in healthcare. Obviously, we have a high volume of patients. And of those patients, we see sicker patients in this post-pandemic arena that stay a little bit longer, have a little more complex condition, some of which is COVID related. Many of us just the structural changes from COVID, some who haven't had much health care in the last few years. And now when they come in the hospital, it takes us a little longer to get them through. So just a complex patient population. And now we're seeing really, really high volumes as a statistic. In the last 3 weeks, we've had almost every day where this medical center has had over 1,000 patients in the hospital. And in all my time, we've never come close to that. It's incredibly busy.
Is that because of COVID?
No, it's what I just talked about. There's a lot of chronic disease here. COVID has made many patients sicker.
Right.
And then so many people, because of the pandemic, have changed how they get their health care. They haven't been seeing their doctor. They haven't been managing some conditions. When you couple all of this together, you get more use of hospitals because patients are a little sicker. But the big issue is what happened in the pandemic to workforce issues. So we said earlier, we will always be challenged in a small town trying to staff one of the nation's largest hospitals. But the nation has had a loss of healthcare workers in this pandemic. There were a lot of exits from healthcare and hospitals when the pandemic began. And over these stressful 3 years, a lot of people have retired out of healthcare. Some have chosen other fields. There's been such a loss of workforce that all hospitals are struggling to staff their hospitals. It's not just nurses. It's a lot of the disciplines. Obviously, nursing gets a lot of the, people are much more aware of that. But that supply and demand curve has had catastrophic outcomes to the finances of hospitals. We are paying 3 times what we paid for some of the extra nursing we have to have, like travel nurses. At the same time that hospitals need more nurses and need to fill the gap with travelers temporarily. At the same time, we have these record volumes. And so what you have is a supply and demand curve that's out of balance. And because, we don't choose to turn it off. We don't say the hospital's not going to take care of the patient who showed up for care. We take care of 100% of them that need to have care in our hospital, regardless of their ability to pay for that or whether it's affordable. And so we take the patients, we put them in the hospital, we staff this hospital, all of our hospitals, with whatever extra help is required to meet that volume at whatever price point the market dictates we have to use. And I'm competing with Cleveland Clinic for staff. I'm competing with Raleigh. I'm competing with Charlotte. Pick any place. It's a national shortage of staff. And so everyone's competing nationally for the price of every individual staff member, and it's created an unaffordable condition.
You're talking about nurses? Are you talking about doctors?
All disciplines.
Do we have travel doctors?
We do. We don't call them travel doctors, but there are locum tenens physicians that are filling gaps for us when we need, between recruiting somebody, it can take us 4 or 5 months to relocate someone here and get them up and going. Right. And during that span of time, we may use some temporary physician support. But, it can be pharmacists. It can be a host of disciplines that it takes to manage a hospital or health system. At times, we've had as much as $20 million a month in the cost of just travel nurses. And that's what we used to spend in an entire year.
You say 20 million?
20 million.
In a month?
In a month. At our peak, we've had to spend as much as $20 million a month for travel nurses. That's more than we used to spend in a year prior to the pandemic. And again, it's not the volume of travelers. I have less travel nurses than I had prior to the pandemic. Yeah. It's not the volume of them, it's the price of them that has really gotten out of control.
So you operate 10 hospitals. It used to be that the only one that actually was in the black every year was Greenville. And then you've got these other 9 hospitals that are in small communities, like my mom was in Edenton to begin with, and they operate in the red. Is that still the case? I mean, does Greenville still kind of, is the Greenville hospital still kind of the cash cow that keeps everything else afloat?
Well, that's an interesting point. I do want to correct it. It's not true that all the hospitals are operating in the red. Some of our hospitals are, like the Outer Banks, does very well financially. A lot of these things depend on the payer mix of the community, though. And payer mix means the mix of how people can afford to pay the bill. And so some communities really have just Medicare or Medicaid or no insurance. Then there are some other communities where there'll be a higher percentage of insured patients. And so the biggest issue is what services we offer, how much the government reimburses for those services, and what kind of payer mix is in the population. So some communities are going to be perfectly designed to not be able to meet the cost structure and not have reimbursement, and they're going to lose money. Our model here, we are what we call an operating company. We don't just have affiliations with our hospitals. They are owned by the organization. And what it means to the community is we are deeply committed to the community. When we bring that hospital on, we have fully assumed liability to render the care in that community, and we don't get to walk away from that. If you're in an affiliation or brand kind of partnership where your name is being shared, you could walk away from the community if it's unaffordable. ECU Health can't. We have committed ourselves to the assets of those communities to provide them, knowing that in many cases, the reason they're on our system is if we're not there to subsidize what is not bad, it just can't make money. We use the dollars that are in one area to subsidize the other because it's really the whole model of care, as you experienced with your mom, that can be in one area, start there, and work its way to the level of care need. To have that, the integrity of all that from a physician in primary care in a community that cannot balance the book through the tertiary level system, it's all a system of care that we are fully responsible for. And so to get it, when you have these cost structures that are out of balance, we saw a $46 million loss of the system. To put that in context, Cleveland Clinic announced just a few weeks ago, losing $1 billion in the first quarter of last year. These numbers are astounding because of these cost structures. We're not unique in that. However, we have to respond to that. We still have to make sure we're balancing our ability to fulfill our mission over the long term. In other words, I don't get an out just because everybody else is facing the same pain. And many times in rural communities such as Eastern North Carolina, you feel that burden even more because I'm not going to have as much payer mix to insulate that or as many insured patients to help buffer that. So our system is accustomed to balancing right at a margin. This is not a hugely profitable health system. We take all our money from one year and invest it right back into the next year. When you look at our system of care, managing clinics is very expensive in 120 locations around Eastern North Carolina, where in some cases, there's not enough patients in the community to keep a physician busy even. Mm-hmm. And in many cases, the clinics we closed, that was the decision we made. We look at where can we do the most good with the limited resource we have, and then where do we have an alternative location that people can get to if we were not there in this particular location, and start with the least negative impact to the community and work our way back from there to help balance.
Their big issue before legislature this time is expansion of Medicaid. We got to get a break in, but I want to come back and talk about that. We're having a lot of legislators on. Some are in favor. Some are very vehemently against it. Yeah. I'm hoping that they'll listen to people like you when they're hearing these issues and maybe reconsider that. And so let's get a break in and we'll come back. I want to talk to you about your position and answer some of the questions that these legislators that are against it may have. Sure. So can we do that?
Absolutely.
All right, we'll be right back with Brian Floyd. Stay with us. We got Brian Floyd in the studio with us. Brian is the Chief Operating Officer of ECU Health, President of ECU Health, and we're talking about these funding issues and where we are in healthcare these days after the announcement that they're going to close 5 clinics. In talking about the shortage of nurses and doctors and staff, if people are leaving the industry, can money fix it? What's the fix here? I know we're going to talk about Medicaid expansion, and that's something I know you're vehemently in favor of, but is money the answer to this?
Well, it's an answer. I wouldn't say that it's any one thing is the answer. People have to want to go into healthcare and do this work, but you do have to be at a market rate that is at the threshold for someone to say, I'm going to choose to do it with you versus do it with someone else. And so what that does is basically equalize the price of staff, right? Because I don't get to choose because it's different in Eastern North Carolina or because we don't have as much payment. I have to pay exactly what the wealthiest health system is paying for the staff if I want the staff to choose to work here instead of choosing elsewhere. We have to be at that threshold. And so what it does is put price at a national number or at a market number, regardless of whether the reimbursement from patient base is also at that same market number, and just creates what is not an equal playing field among health systems. But that's why programs exist at the federal level to help augment the condition of a community. Eastern North Carolina, there are other communities similar to ours where there's just a very different payer mix, and rurality is a big part of that story. Where you just have different ability to pay from the local economy. And Eastern North Carolina has a lot of tier 1 economic communities, meaning that they're very socially vulnerable. And in those communities is where we've set our mission. That's where we have our hospitals. That's where our clinics live. It's our mission to reach those most vulnerable communities. And when you look at it that way, the government has programs then that are meant to say, well, if you're going to do that, we have to help you balance that in some way. Mm-hmm. And Medicaid is one of those programs. And the expanding Medicaid simply says if you've got a larger percentage of people without insurance in your community, we are federally regulating that you have to render the care to those patients. You don't get to choose based on their ability to pay which ones you're going to care for. And we say we're all in. We're gonna own these hospitals, own these clinics. We're going to make sure these patients have the best care that we can get to them. Then they say these programs are meant to augment your ability to not go under trying to do that. The problem becomes that those programs require elected officials to put them in motion. We are the poster child for why Medicaid expansion exists. As some of the other programs. They're built for places like ours.
Well, you've talked about the payer mix and the fact that, in Eastern North Carolina, a lot of people don't have insurance. They don't have enough insurance. Right. And so the hospital is stuck with a bill. So I get that. But let me throw out, and again, Medicaid expansion is going to be a white hot topic here in the next few weeks in Raleigh.
Sure.
let me throw out some of the objections we're hearing from legislators. Of course, the big one from the beginning has been that it's a federal government program, and do you really believe, federal government's supposed to pay 90% of this, state's supposed to pay 10% of it. Do you really believe, with the shape of the federal government, that they're really going to stick to 90%? Now, Phil Berger said on my show 2 weeks ago that he's gotten beyond that he believes that the money will be there to reimburse. So I don't want to spend a lot of time on that one, but here are some of the other ones that I've heard recently we've had on the air from legislators. We can't manage this. Medicaid's been managed so poorly in North Carolina. It's so full of fraud. Why would we want to put more money into a fraudulent system? So how would you respond to that?
Well, I think that it's easy. My personal opinion is that it's easy to imbalance this conversation. It's a very complex issue, and yet there's always, managing Medicaid is a government obligation that is challenging to meet. No question about that. Having said that, though, let's remember what we're doing. In Eastern North Carolina, and I'll pick us. This is true in other places too, but in our market, I look at it from the perspective that healthcare is not entirely a cost. Now, it's easy if your focus is the cost of rendering care, the cost of a Medicaid program, let's say. But you also have to look at the benefit to the GDP of the healthcare system itself. So ECU Health generates over $4 billion economic stimulus to Eastern North Carolina through job growth and other resources that come as a result of ECU Health operating in Eastern North Carolina. Well, 60% of all the money coming through our health system is federal dollars through the Medicare program, not the Medicaid program. Then you have a large portion that comes from the insurance population and a small percentage that is Medicaid. But you get the economic benefit of all the money.
Okay.
And so it would be unwise to look at it from purely the cost of Medicaid unless you look at it from the perspective of the economic benefit provided on the other side of it, if you were purely looking at it economically.
We got 2 minutes left, and I got to ask this last question because this might be the key to getting something done in this session. Some legislators are saying, I'm for expansion of Medicaid if the hospitals will give up their certificate of need, which of course means that you would lose a lot of money doing surgeries. And again, I know you probably need more time, but I've only got like a minute for you to answer that.
It's a complex issue. Basically, just keep in mind this. The certificate of need protects that anybody can just set up a surgery center and move patients out of the hospital environment. If you're setting up a private business of doing surgeries, you're only going to take the insured population to make money on that. But we are federally required for all population. And so what it basically does is allow the few that pay, the less than 10% that are actually have insurance to pay the bill, to have their care rendered outside the surgery center, which does save insurance money. It does save some people some money. But the cost of that is that you leave behind all the non-paying surgical patients in the most expensive place where you still have to have
these doctors
all those
that want to do
resources.
surgeries in their office don't want to do it for patients that don't have surgery.
Correct.
They don't have insurance.
And they're not required to do it. The hospitals are.
So the bottom line is your surgery, the surgery revenue, of course, is part of what's propping up the hospital.
It balances the books for hospitals. Yes.
So if they want you to give that up to give Medicaid, it doesn't make sense to you.
And we've agreed to pay the state's portion of Medicaid. The hospitals have agreed to pay for the state's portion. It's hard to do that commitment if you're also going to unwind the business model that makes it whole.
This has been great, and we're up against a hard break. And Patrick, I apologize. We blew through Patrick's time too, but I really felt like this was important and really interesting for everybody in Eastern North Carolina to hear. So thank you for doing this. 10 seconds.
Yeah, I just want to say to the public, thank you for your trust and confidence. I have confidence we will work through this. I have confidence our elected officials will help us be successful in the future. We're still delivering our mission to Eastern North Carolina. These are sometimes hard decisions, but the right decisions to balance the whole. And please know that we're here for you, and none of that has changed as we make some of these adjustments.
And call your legislator and tell them that you heard Brian Floyd explain this, and they need to vote yes on Medicaid expansion.
Absolutely.
We're gone. Thank you so much, Brian.
Thanks.